I'm going to present the results of the study on effectiveness of conjugate typhoid fever vaccine done in Harare, Zimbabwe, in collaboration with the MOH, MSF-OCB, and Epicentro. Zimbabwe has suffered regular outbreaks of typhoid fever, with most of the cases reported concentrated in Harare, the capital city of the country. Since 2010, there have been recurrent peaks occurring every year from October to March. In the graph, we can see the number of cases per week, and that by the end of 2017, the number substantially increased, with almost half of the cases being children that we can see in the blue bars. It was also observed a concerning increase in the resistance to ciprofloxacin, which is the first line of treatment for typhoid fever in Zimbabwe. Some areas in Harare are particularly affected by typhoid fever, and this is likely related with the poor water and sanitation conditions in a densely populated suburbs in the southwestern area of Harare, as we can see in the map. Approximately 70% of the reported cases came from 3 densely populated neighborhoods that are Glenview, Mbare, and Kwatsana. We can also see in the graph that the attack rates were higher among young children. In Mbare, shown in the green bars, the attack rates were high in all age groups, including adults. There are 3 types of typhoid fever vaccines available. The first 2, most used previously, had some limitations. The parenteral unconjugated vaccine or the oral live attenuated vaccine cannot be used in children younger than 2 years old. The oral vaccine needs multiple doses, and both provide a modest level of protection, and the duration of immunity is limited. The third type is the typhoid conjugate vaccines. WHO recommends these vaccines for use in routine immunization in typhoid endemic countries. These vaccines show in clinical trials good efficacy, provide longer-lasting immunity in young children, and can be used from 6 months of age. The first conjugate vaccine to achieve WHO pre-qualification was Typbar in the late 2017. A second conjugate vaccine, Typhoid, was recently pre-qualified. To prevent and control the 2019 seasonal peak, and due to the concerning increase of the resistance to ciprofloxacin, the Ministry of Health in Zimbabwe conducted a mass vaccination campaign with a Typbar conjugate vaccine during 8 days by the end of February of 2019. The targeted areas included the 9 most affected suburbs in the southwestern area. The target population included everyone aged 6 months to 15 years, and in Mbare, adults up to 45 years were included due to the high attack rates seen in all the age groups. The results of a coverage survey done in April 2018 reported a vaccine coverage across the 9 suburbs of 85% in the younger age group and 65% among the adults in Mbare. After the vaccination campaign, an evaluation of the Typbar vaccine effectiveness and the real conditions was initiated. The primary objective was to estimate the effectiveness of 1 dose of Typbar conjugate vaccine against confirmed symptomatic typhoid fever infection in individuals between 6 months to 15 years. The secondary objective was to estimate the vaccine effectiveness in individuals aged between 6 months to 45 and against confirmed or probable typhoid fever cases. Additionally, it included strengthening surveillance and monitoring antimicrobial resistance. The study population included inhabitants aged between 6 months to 45 years residing in Glenview, Mbare, or Kwatsana at the moment of the mass vaccination campaign. We prospectively recruited in 4 health facilities located in these suburbs. You can see the location in the map, confirmed typhoid fever cases that were compared with two different sets of controls, facility controls and community controls. The vaccine effectiveness was measured comparing the odds of vaccination between these groups. For the study, a suspected typhoid fever case was a patient with fever at least 38 degrees that lasted for at least 3 days. A probable case was a suspected case with a positive serodiagnosis test but no Salmonella typhi isolation in a blood culture. And a confirmed case was a suspect case with a laboratory confirmed blood culture of Salmonella typhi. I will start showing now some results of the study. 707 suspected cases were screened in the health facilities. You can see in the graph in gray and yellow the confirmed and suspected cases. Enrollment started in July 2019, continued up to March 2020 when it was interrupted due to the COVID pandemic, and restarted in July in Harare, and then in November, the second clinic in Glenview was also restarted. The study ended in April 2021. We collected information on 504 suspected cases on vaccination status, signs and symptoms, and other potential risk factors for typhoid fever through a questionnaire. We also collected samples for blood culture and serology. Out of the 504 suspected cases, 148 had the blood culture positive for Salmonella typhi. And overall, 60% of the cases came from Glenview. In the graph, we can see the trends of suspected cases per quarter from 2016 up to 2021, before and after the vaccination campaign, with data coming from the surveillance system in the street suburbs where the study was conducted. In relation to the age distribution, we observed that confirmed cases were mostly adults, and only 31% were under 15 years. In the graph below, we can see the age distribution per suburb, where we see the same distribution except for Quatsana, where the number of confirmed cases was very low. This table shows the baseline characteristics and some of the risk factors collected in the three comparison groups in the participants between the 6 months to 15 years old, what is the main objective. The sex, age, and resident place were the matched variables. The cases more likely consumed food or drinks from the market or the street, did not have a latrine or it was flooded, and used more frequently a borehole and treated as a source of drinking water. We found evidence of this in the control group when compared to community controls. Sorry. This slide shows the results of the main objective. In the primary analysis, which included individuals from 6 months to 15 years, the adjusted vaccine effectiveness estimation for one dose of Typbar vaccine can be seen in the pink column. It was 75% when confirmed cases were compared with facility controls, and 80% when were compared to matched community controls. In the secondary analysis, when individuals from 6 months up to 45 years were included, the vaccine effectiveness estimations were lower, keeping in mind that adults residing in an endemic area has been exposed longer to Salmonella typhi. When the analysis included not only confirmed but also probable cases, the vaccine effectiveness was also lower. In May 2018, MSF and the Ministry of Health analyzed around 200 Salmonella typhi positive samples and found high levels of resistance to several antibiotics. The most alarming pattern was reported in Quatsana suburb with 73% of resistance to ciprofloxacin. The bars in yellow show the resistance patterns that we found in the study. So to conclude, the vaccine effectiveness in our study was assessed under real conditions after a mass typhoid conjugate vaccination campaign in an African setting. One vaccine dose of the conjugate vaccine can be an effective tool to control typhoid fever in the population aged between 6 months to 15 years. We did not see further resistance increasing trends to the used treatments, ciprofloxacin and azithromycin, and no resistance to ceftriaxone. And this kind of a study allows monitoring and understanding the vaccination dynamics of typhoid fever in an endemic area. So to finish, I would like to thank all the people who made possible this study, especially the participants and the teams in Zimbabwe. Thank you.